During this episode of Banner Health's Making the Rounds podcast, we will be discussing pediatric orthopedic surgery, how it's different from general orthopedics, and why specialized care for treatment is so important. We'll also talk through some of the advantages your patients have when they're treated at a Banner Health facility, thanks to our multidisciplinary team of providers and healthcare specialists. To learn more about these topics or other pediatric-related offerings at Banner Health, please visit bannerhealth.com/pediatrics. Making the Rounds dives into medical topics with those who know them best, healthcare providers. My name is Bridget, and I'll be your host for today's episode. If you're new to our podcast, thank you for tuning in. And if you're a regular listener, welcome back. With me today is Dr. Ryan Miller, pediatric orthopedic surgeon at Banner Children's and associate professor of orthopedics and child health at the University of Arizona College of Medicine, Phoenix. Thank you, Dr. Miller, for joining me today, and welcome to Making the Rounds.
Thanks for having me.
Well, thanks for joining. Tell us a little bit about yourself, Dr. Miller.
Well, I am about as old school Arizona as you can be. I have lived here my entire life, and I grew up right here in Mesa. All of my kids have been born here at Banner Good Sam. So when I was in residency, so we are very tied into Banner. I did my residency through Banner here in Phoenix as well, and then went to a small pediatric orthopedic hospital in Dallas called Texas Scottish Rite Hospital, and then came back to work. So I always wanted to come back and work at home and be here close to my family. We have big families on both sides, on both my wife's side and my side of the family. So this is home to us, and we don't plan on leaving.
Wonderful. How'd you get into pediatric orthopedics?
Yeah, I think orthopedics, I didn't really know what it was going into medical school. And somebody, a few people along the way mentioned, hey, you might like orthopedics. And so second year of medical school, I shadowed a couple of orthopedists, and within about 10 minutes knew that that's what I wanted to do. And from that moment on, just sort of committed myself to doing it. I was interested initially in being a pediatrician. And so at some point during my orthopedic surgery residency, I think that came back a little bit and decided to do pediatric orthopedics.
Well, we're glad to have you here, not only in Arizona, but here at Banner Children's. So thank you for joining us today. So, you have children, you know about all their bumps and bruises and scrapes. And we all know that children and the likelihood that they'll experience a fracture or an injury at some point during their childhood development. But let's start by defining pediatric orthopedic surgery. Dr. Miller, what distinguishes pediatric orthopedics from general orthopedics, and why is the specialized care for children so essential?
Yeah, I think when you were mentioning my family in pediatric orthopedics, I think out of my 4 kids, we've had 2 of them get fractures. My 5-year-old got a fracture about this time last year and was in a long leg cast for 5 or 6 weeks, which is a challenge. So this is definitely an issue, even my own home. I think pediatric orthopedics is unique for a few different reasons. I think the patient population is obviously wonderful. We spend our time with kids, and kids always have that special energy that kind of keeps me going. And I think that they are moving targets. So that's the beauty of children, is nothing is static. Everything is alive and everything is changing all the time. And so I think pediatrics orthopedics is dealing with change. It's dealing with a moving target. It's dealing with something that may not need your help. Is a lot of pediatrics orthopedics in knowing what you don't need to do because it's going to take care of itself. So I think those are some of my thoughts on that.
Thank you for that. In pediatric cases, Dr. Miller, they require a delicate approach. The children orthopedic is a little bit different and unique, and due to the children's ongoing growth and development, what unique challenges do pediatric orthopedic surgeons face compared to their counterparts dealing with adult patients?
Yeah, I think one of the most important things about pediatric orthopedics is knowing when you don't have to do anything, or that you shouldn't do anything. And there's a lot of that. I think, if you look at a adult orthopedic surgeon, if they see a certain amount of patients in clinic, they're going to operate on a pretty big portion of those. In my clinic, you have to see a lot of kids to find some that need surgery. And I think that's, a testament to just Mother Nature and how she's created these little children that can grow and improve mostly on their own. So I think that's the first big difference is there's a lot of things that don't need anything. And that's the trick, is knowing what doesn't need to be operated on or dealt with in any way. I think from there, one of the things that people always think about with regards to pediatric orthopedics is the growth plate. And certainly we like to consider ourselves experts on growth and the growth plate itself, especially fractures around the growth plate and how growth sort of aligns with all of our orthopedic conditions. And so certainly we spend a lot of time talking about growth and how that affects the developing musculoskeletal system over time.
I like how you mentioned that, although this podcast is discussing pediatric orthopedic surgery, not every case requires surgical intervention.
Oh, far from it. Yeah, I would say a very small percentage needs surgery. And I always tell families that if a surgeon tells you not to operate, listen, because that's usually the best thing not to do.
Absolutely. That's great advice. Could you share some of the common conditions that pediatric orthopedic surgeons often encounter and how these conditions are typically treated? So if we're talking about, the non-surgical conditions.
Yeah. So I think some of the most common things that I deal with in clinic are things like in-toeing, or my kid's legs look funny, or his or her feet look funny, or just little concerns that parents have about the appearance of their child's musculoskeletal system. And I think a lot of times families are just need some reassurance on what is normal and what isn't normal. And hopefully we can provide some guidance in that way. I think a lot of times my answer is, let's just keep watching this. And the vast majority of these things sort themselves out on their own. And unfortunately, some families feel like you have to do something now or something terrible is going to go wrong. But in pediatric orthopedics, especially, that's almost never the case. And hopefully we're able to give families enough information that they can trust us that with a little bit of time, this is more likely than not going to sort itself out. So I think there's a lot of that kind of thing. And then obviously we see a lot of fractures, which are very common in young people due to their growing skeletons, their bone structure, and things like that predispose them to fractures in those early years. And again, the vast majority of those require no surgery at all, just immobilization, a cast or a splint for 4 to 6 weeks. Most of the time we can let them keep walking on things, moving around. And obviously there's more serious cases, but the vast majority of these fractures just require some careful immobilization and watchful waiting, follow-up x-rays and things like that. And they do fantastic. And the kid gets back to doing everything as if nothing ever happened. Certainly that's been the case in my house with some fractures that we've had.
And so you mentioned some of these common cases that you treat, but you also provide care to children dealing with more complex orthopedic conditions. Could you elaborate on some of those specific types of conditions you do encounter?
Yeah, I think in my practice, the main, the classic pediatric orthopedic conditions are ones that we see a lot of. And those are things like scoliosis, hip dysplasia, arm and leg deformities, spine deformities, congenital conditions like club foot or other foot deformities and limb deformities that children are born with. We take care of a lot of those types of conditions. And I feel like in our group have a lot of expertise in those things.
Dr. Miller, let's discuss scoliosis. So scoliosis is a condition that affects the curvature of the spine, right? And, this is probably something that many families or, many of our parents or pediatricians that are listening may have a slight, curvature here or there, or they have a family member that is, that has been diagnosed. But when we're talking about children and we're talking about the diagnosis of scoliosis, when are most children diagnosed with scoliosis? And is there an appropriate screening process?
Yeah. So I think the vast majority of scoliosis is what we put in the category of adolescent idiopathic scoliosis. And that's the most common type of scoliosis. It typically comes on during the teenage growth spurt and gets picked up by their primary care doctor. Turns out the vast majority of those don't need any surgical treatment at all. Some need a brace, and very, very few need surgery. And again, those are typically picked up at school screenings. Primary care providers pick those up on annual exams because they're typically non-painful. The kids are doing everything normally, and then they'll get picked up on a routine screening exam. And so, different schools and primary care providers have different protocols that they follow as far as screening. And all of those are great. And we certainly try to participate in some of those training programs to help our community colleagues know how to do those. But yeah, I think those are the main things as far as diagnosing that most common kind. There's certainly, scoliosis that comes on in other kids at younger ages. And those are typically, found by their primary care provider, some other physician or practitioner.
But what's the earliest child that you've ever seen that's been diagnosed with scoliosis?
So certainly there are cases of early onset scoliosis, and those kids can be seen as newborns with scoliosis. And so, typically you're watching them for the first few months, but yes, we treat scoliosis in children, 1, 2, 3 years old. Surgery is essentially never the answer in those very young kids, but we do some casting, which is kind of like a body cast that's put on under general anesthesia, and do bracing in those years. And in very extreme cases, though, some of those kids will require an operation with a specialized kind of implant that is designed for growth. But in general, you want to try to put off surgical intervention as long as possible in those severe cases.
So when we're talking about there's a large age spectrum, that a child could be diagnosed with scoliosis, what is that optimal age for initiating that scoliosis treatment? And at what degree does surgery become a consideration?
Yeah. So I think in general, the two determinants of treatment on scoliosis is the size of the curve and then how much growing that child has left to do. Growth is typically what drives scoliosis. And so as a child grows, then their curve is going to continue to grow, assuming that they already have a curve. And so if a very young child has a, moderate to severe curve, well, that certainly perks our ears because those kids are going to have a very big risk of progressing to the point where their curve needs surgery. Depending on the age group, there's different parameters that we use for treating scoliosis. But typically, once the curve is getting up into the 20-degree range, we're starting to think, okay, this is maybe going to get serious. And if they have enough growing left to do, we're going to start talking about things like bracing and casting in the very younger children, and see if we can slow this curve down. Surgical intervention in my hands is reserved for people with curves, 50 degrees and over. And that's not a hard line in the sand. That's something that I talk to families about. There's no hard number where, if the curve gets this big, we have to do something. I think that's always sort of a shared decision with the family of talking about what the pluses and the minuses of surgery are. I mean, spine surgery is obviously a massive operation with a lot of downside to it and certainly some risk. And so trying to avoid that as much as possible is always a good idea. But in the right patient, if the decision's made carefully, and I think if the decision's made with the family and everybody understands, I think it's very beneficial and is great for the kids, and they do very well with it.
Can you share with us a little bit more about those surgical treatment options and how they're performed?
So I think the mainstay still to this day of scoliosis surgery, especially in the older adolescent children's, is a posterior spinal fusion. And that involves simply opening up the spine, loosening it up as much as possible in order to get a correction of the curve, placing, instrumentation in the spine. In my hands, that's screws and rods, trying to straighten the spine as much as you can safely, and then letting the spine fuse over that area. And basically the goal of that surgery is to prevent the curve from getting worse. I think that's the primary goal. I think the secondary goal is to try to get as much correction of the curve as you can and restore the appropriate balance in both planes of the spine. So the frontal plane and then the sagittal plane of the spine where you're looking at it from the side and the front. and making sure you restore that as closely to normal as you can, because that's what we know provides the best outcomes.
Thank you for that overview. Could you provide some insights into the recovery process, and what are some of those, if any, the limitations or considerations for these parents to know about or for the patients to understand?
Scoliosis surgery is obviously a big deal, but I think we have, pathways designed that really get kids back on their feet fairly quickly. So, in my hands, the day of surgery, the child hopefully stands up and takes a few steps. We have a lot of pain management modalities that we use to try to keep the pain as controlled as possible. Post-op day 2, that patient is going to stand up and hopefully, be able to walk to the bathroom, walk to the door a couple of times during that day. Hopefully they're starting to eat, drink on their own, and starting to feel a little bit better. But post-op day 2 is usually pretty rough. And then, as they move forward each day, they're doing more and more walking, standing, eating. And, we have patients go home on post-op day 2 and post-op day 3, I would say is typical. Some of the bigger spine operations that we do where we're doing longer fusions in children with more complex medical problems, those kids can stay in the hospital for 5 or 6 days. But I think in general, families are pleasantly surprised by how smoothly things go in the hospital after the surgery. And the kids leave walking around with their pain reasonably well controlled, and they typically miss 2 to 3 weeks of school, and then they're kind of getting back at it. I'm pretty aggressive about trying to get kids back to school, just because I think that's where kids belong, is getting back with their friends and at school. And I think that sort of speeds the process up a lot.
Is there any physical therapy or any rehab that's ordered after those surgeries?
Yeah, so I think the answer is always yes. I think physical therapy is important, and I don't know that it necessarily has to be with a physical therapist. That's what I'll tell the families is the physical therapists are there to help us if special needs are there. But I think some of the best physical therapy after the scoliosis surgeries is just getting up and walking, getting back to normal activities. Certainly patients that need extra help will work with a physical therapist on strengthening, and it just sort of depends on how they come into the operation. I think the nutritional side of it's very important, getting the kids eating again, eating nutritious things, so they're getting enough of the building blocks to heal appropriately. I think that's a big one in my hands. And but I think for the most part, these kids do well and get back to real life pretty quickly.
That's wonderful. Thank you for the details and the overview on scoliosis. So, talking about some more of the complex cases that you treat and see, I'd like to move on to hip dysplasia. Can you provide us an overview of what hip dysplasia is?
So, hip dysplasia simply refers to the development of the hip joint from the time the child's conceived in the womb until they're born, and then moving out, throughout their life. Hip development occurs over that whole span. It usually goes wrong in the beginning. And there's definitely a few risk factors for hip dysplasia. The biggest ones are children who are breech during the pregnancy, and that's just to some positional issues that happen with a breech child and the hip joint not being concentric or completely in the socket during that time. And that changes some of the muscular balance around the hip joint, and the hip socket won't get as deep, and the surrounding structures, the hip capsule and the muscles, aren't working in a coordinated fashion to keep that hip joint in the socket. And with that, you get a little bony deformity, and ultimately the hip joint isn't as tight, I guess is one way of looking at it, where the hip joint is moving around inappropriately in the hip socket. And those are super common cases. Every child who's born, the pediatrician makes its rounds, and the pediatrician checks the hips. And if there's any concern at all, they'll make a referral or get an ultrasound, and then they'll end up in our clinic. And from there, in the young infant, the treatments are pretty standard. It's a what we call a Pavlik harness. It's simply a harness that goes over the shoulders and holds the legs in a position that lines up the hip joint. And with that with that alignment, the hip joint typically starts to remodel and reform into the appropriate way. And those surrounding structures of the hip capsule and the muscles around the hip joint will start to tighten up. And the vast majority of those kids we can treat with just that. It requires no surgery. It's a very minimalistic intervention that works very well. If children make it past that first 6 months to a year and, they had a hip that was dislocated and wasn't caught, or severe dysplasia, sometimes that can necessitate more aggressive treatments. We have different types of braces that kids wear. Sometimes we have to take them to the operating room, put them to sleep, and put them in a cast that holds the hip in place. And then, from there, if some of those interventions don't work, then you're talking about certain surgical interventions to either put the hip in the socket or sort of reform the hip socket in order to create a stable hip joint for the child.
That was going to be my next question, is when is hip dysplasia diagnosed? But you're mentioning that, hip dysplasia can be diagnosed at the time that the pediatrician's rounding after birth. So that leads me to my next question is, you gave a situation as to where a breached baby could develop hip dysplasia. Can hip dysplasia be a congenital disorder?
Yeah, so I think the terms congenital and hip dysplasia have sort of morphed over certainly my career. And I think generally at this time, we all use the same terminology of developmental dysplasia of the hip, or DDH. I think they're all sort of variations of the same problem. It's something that happens over time. There's a lot of different things that can affect it. And those are typically abnormal forces on the hip, whether they're from positioning in the uterus to neuromuscular conditions that children may have that put abnormal forces around the hip joint. So those are all things that can affect it, but the end result is the same in that you have a hip socket that is not lined up appropriately, and the ball is wanting to come out of the socket, and you have to take measures to make sure that it stays stable.
You just mentioned neuromuscular disorders. Can you elaborate on that diagnosis?
So I think as far as the neuromuscular disorders and hip dysplasia goes, we take care of a lot of kids that have conditions like cerebral palsy, muscular dystrophies, different chromosomal abnormalities. And many times those translate to physical conditions in the children where their muscle tone is abnormal. And when you have abnormal muscle tone, that can affect the hip joint and the hip joint lining up appropriately. And with that, then the hip joint over time does not develop appropriately. And in those cases, we have a lot of different options that are initially centered around controlling different tone in the muscles. So for kids with cerebral palsy, you can try things like Botox and other medications that help control the tone of the child. And bracing is always an option. A lot of follow-up radiographs, and some, like anything else, some of those kids do end up needing surgery just to overcome the neuromuscular part of that we can't overcome with bracing or non-operative measures.
What happens if hip dysplasia is missed or left untreated?
So I think the worst case scenario there is a hip dislocation, a congenital hip dislocation, or a hip that was dislocated at the time of birth and that wasn't found. And the good news is I think we have reasonable answers for those. I would say it's very rare in today's world that a child makes it past 2 or 3 years old with a dislocated hip before they find treatment. But certainly we see those in our clinic on a fairly regular basis. I'll see 1 or 2 a year where a child comes in and they've had a dislocated hip that's never been found. And usually at that time, if they're 2 or 3, that's going to involve a procedure where you do an open surgery and place the hip joint back in the socket, and often have to do some surgery on the pelvis side to create a socket that's a bit more stable and can keep the hip in the socket.
As with scoliosis, are there specific factors that influence treatment options, whether it's bracing, surgery?
Yes. So I think the major things with scoliosis are age at the time of diagnosis and then the severity of the condition. So whether the hip is just sliding around a little too much, whether it's dislocated just a little bit or a very high riding dislocation. And then, like I mentioned, the age. So, if the child's under a year, many times we can take that patient to the operating room and without making any incisions or doing any open surgery, we can put the hip back in the socket and then put the child in a cast, and then over time that hip will stabilize without any surgical intervention.
Dr. Miller, we've reviewed spine and hip conditions and their treatment, whether it's non-surgical or surgical interventions. But as you mentioned earlier in the interview, there are some congenital conditions you treat, such as clubfoot, limb deformity, and other disorders of the skeletal system. How do these conditions really impact a child's development, and what treatment options are available?
So I guess I would start out with clubfoot. That's kind of one of my personal favorites. I take care of a lot of club feet and do most of that here on for our practice. I think that clubfoot is one of those things that's very obvious at the time of birth, and I think it's one of those things that's very disconcerting for the family to see that deformity. The good news is we have a program here at our hospital that tries to get these families in touch with me even before the child's born. So we have a fetal program where once the family has an abnormal fetal ultrasound that shows a clubfoot or another congenital deformity, that they can come and see me before the child's even born. And I think a lot of the families really like that opportunity to come and ask some questions and get some direction on resources and things like that to sort of wrap their mind around this before the child's born. I think that's helpful. So ideally, when the child is born, the family's already had contact with me. They've already had some paperwork that this kind of helped them through that. They've watched some videos and things like that that can help them understand. And then I simply tell the families with regards to clubfoot, enjoy the birth. Just like you would any other person, just love that little foot and that little baby, and then let me deal with the foot. And so, they come into my office 1 or 2 weeks after the child's born, and we start casting the child. And that's a weekly process. For 4 to 6 weeks, we'll put on a new cast every week, and ultimately sort of slowly move the foot out into position. The child then does require one small surgical procedure where they get a 4 to 5 millimeter small incision in the back of their foot around their Achilles tendon that typically needs to be lengthened. And with that, they go into another cast. And then that's when the real work begins for the family, where they have to do some bracing until the child's 4 years old. But ultimately, the good thing about clubfoot is untreated, it's a challenging condition that that can really affect somebody's life. But treated, these children are essentially normal. They're running, jumping, doing everything completely normal. If you saw some of my clubfoot kids running around, you would have no idea that they had a clubfoot.
That's great. So in discussing, we're talking about this is a few weeks after delivery, and you're saying, these are little guys on the playground running around. In discussing growth and development, these considerations, how do you approach the surgical management and decision-making process for these injuries or congenital conditions?
Yeah, I think just in general, this is shared decision-making with the family. I think knowing, again, I can't reemphasize enough the importance of knowing when not to do something. I think that's just probably the most important part of my job, is knowing when not to do something. And the more gray hair I get, I think the better I am at making that decision. And the more things I leave alone. But I think that is the most important thing, knowing when not to operate, and then knowing when to operate on the right indications. And I think hopefully that happens as you've built a relationship with that family. Almost nothing are you going to come and see me the first time and be like, yep, that needs surgery. Let's load them up and haul them off to the OR. That just doesn't happen in pediatric orthopedics. I mean, most of this stuff we're watching for a long time before surgery comes. The family's had a lot of time to think about it. We've talked about options. And I think for the most part, by the time it comes, the family is ready for it and is comfortable with the decision to move ahead with the operation.
That's so important. That relationship and partnership with the parents is really vital in that child's healthcare journey and is key for those successful outcomes. Just as you're talking about that collaboration and that relationship with the parents, Can you share with us a little bit about your relationship with the pediatrician as you're talking about, we're going to watch these children. We're going to see where they're going over the next couple of years, couple of months. You're in communication with your referral source. So that relationship with the pediatrician is an important piece when it comes to diagnosis and treatment. Can you share how you and your team collaborate with that referring provider and how it's positively impacted the care in your practice?
Yeah, I think certainly in this community, we're blessed with a very good set of pediatricians who are concerned and smart and enrolled in the treatment of their children. And we work with a lot of banner pediatricians. We work with a lot of community pediatricians, and my experience has been nothing but positive in working with those doctors. Certainly, more complex cases require more complex communication, and a lot of that develops over time. Certainly when I was younger, I made a lot more phone calls, and now people have, pediatricians have my phone number and can text me certain things. And we have a hotline to let the pediatricians get in touch with us if something's coming up in addition to the normal things like sending them their notes and things like that. But yeah, I certainly have, I feel lucky to have good relationships with the pediatricians here in our community, and certainly our referring pediatricians. And I think that is a very positive thing when a pediatrician feels comfortable with the specialists that are taking care of the kids.
Are there ever any cases, we understand that pediatric surgeons work closely with other specialists within our Banner Health Network. Are there any cases where you collaborate with other pediatric surgeons, whether it's in surgery, whether it's in the non-surgical treatment of these patients? As you mentioned, with some of these congenital cases, there are some other either malformations or other genetic anomalies that may happen at time of birth. Can you share with us a little bit about that collaboration with your Banner Health specialist?
Yeah, I think pediatric orthopedics is definitely a team sport. A lot of these kids that we take care of have complex medical conditions and certainly need a lot more people than just me. And I'm very grateful for those people. I think first and foremost, are my partners, Dr. Goggins, Dr. Udall, Dr. Vu, and Dr. Nye, who are the latter, over at Banner Thunderbird. I think we have a very solid group of pediatric orthopedic surgeons here. I'm always asking their advice and getting input on different cases that we have. I think, between the five of us, we definitely have the ability to cover the gamut of pediatric orthopedic surgeons. So I think that's sort of the basis of it for me. Here we also have a very active pediatric neurosurgery group and work closely with them. A lot of those spine conditions does require input from neurosurgery. We have a neurosurgeon here, Dr. Alexiades, who has a pretty significant interest in cervical spine deformities in pediatrics, and is very good at that. So we're sort of developing more and more of a program for cervical spine deformity here at our hospital. I think that's been wonderful to sort of collaborate with them. And additionally, our pediatric surgery team is very good. All of us, end up taking care of all of these patients sort of together: neurology, endocrinology. I mean, I could go through every single one of the subspecialties. Our pulmonology team sees all of our scoliosis patients before and after surgery. Our ICU team is absolutely critical in the postoperative care of our patients. And we have a very big, active pediatric ICU here that does a great job of taking care of these kids. So I like I said, this is a team sport and everybody's involved in it. And nobody is an island, that's for sure.
I love that. Dr. Miller, when we had originally, when we did our discovery conversation with you, you had mentioned prehab and rehab and some of that post-care, and you had shared with us that you and your team do a lot of that education for these patients. Can you elaborate on that care, that personal care that you provide your patients?
So I think getting patients ready for surgery is a bit of a neglected art in medicine. And I think luckily, we're sort of at a hinge point where people are starting to pay more attention to this, and we have some technological potential solutions that can help with this. I think in my mind, I think maximizing the health of the patient, especially before a big operation, is of utmost importance. In the real young children, there's maybe a little less that you can do, but certainly as children get older, you can start looking at things like their nutritional status heading into surgery, their nutrition that they're getting after surgery and how that impacts their healing. And certainly very interested in this. My wife's a dietitian, and so we talk a lot about how this may and may not work. But certainly that's part of my pre-surgical plan, is talking with patients about how they can optimize their nutrition pre and post-surgery, and how that relates to their activity levels and getting back to what they want to do, and hopefully avoiding some of those complications that can potentially come. But I think all of those things are critical and make big differences in how patients do after surgery.
So finally, Dr. Miller, what advice would you give to parents or referring providers who may have a child in need of orthopedic surgery, or that would be maybe looking for an orthopedic consult?
I think that the advice that I give to my patients and my family is to find someone that you can create a relationship of trust with, and then stick with that person. And I think we're blessed here in town that we have a lot of really great pediatric orthopedists. I think having that continuity and that trust is probably the basis of the treatment, even more than the exact treatment itself. And many times those are going to be the same anywhere you go for certain conditions, et cetera. But there are certainly complex pediatric orthopedic conditions that are very nuanced, very complicated. And I think that relationship with the physician is probably the most important part of it.
That's wonderful. I appreciate that. It's definitely, I mean, even in adult medicine, a relationship with your physician is so vital to your care and that your treatment pathway. So, Dr. Miller, is there anything else that you'd like to share that we didn't cover today?
No, I think, yeah, to wrap it all up, I think I'm just grateful to be working in this field. I think it's wonderful. The chance that we have to work with kids and their families is fantastic. You walk into my office and it's alive. It's very much alive. And I think that's the beautiful part of my job.
Oh, that's beautiful. Dr. Miller, thank you so much for being with us today and sharing your expertise and insight. We truly do appreciate your dedication to improving the lives of our pediatric community, one little bone at a time.
All right. Well, thanks for having me.
Thanks for being here. If you found this conversation as informative as we did, please subscribe to our podcast for more discussions on important medical topics. To learn more about Dr. Miller and the pediatric services available at Banner Children's, please visit bannerhealth.com/pediatrics. Thank you for listening, and we'll see you next time on Making the Rounds.